चलो चालू करो.
Should I start, sir?
I think so. Anybody else is joining?
Ubaro.
Over the year.
હવે નેશનલ એન્થમ ચાલો. નેશનલ એન્થમ ગાઈએ. પિક્ચર ચાલુ થવાની છે.
જણા કોણ આવ્યા છે? હું છું, આરએક્સ ઇવેન્ટ છે, આસિફ છે, એચઓસી વેદાંત, જમોન જોની, અભિષેક કકરુ, ભરત પરી, કલ્પેશ પ્રજાપતિ. એટેન્ડીઝ કોણ છે? ઓકે, આંગળી ઊંચી કરે છે ને? શ્વેતાએ આંગળી ઊંચી કરી છે. એને ક્યાંક બોલવું છે? એને ચેટમાં લખ અહીંયા. એચઓસી વેદાંત લખ્યું છે કોણ છે? ભાવિન છે?
ના, જોમોન હશે.
જમોન તો હવે મહેન્દ્ર ધોની છે.
જોમોન ધોની છે.
હા
ચિરાગ ચાલુ કરો.
હા, નારિયેળ વેળે ફોડો, હવે ચાલુ કરીએ.
So should I start now, sir?
Yes, yes.
So good evening.
Dr. Edis people, do you want to formally welcome and then start the treatment? Start the proceedings? Or we can start? Chalo, mount che. Asif, you can start.
Sure. Good evening, everyone. I'll be discussing evidence-based consideration in selecting CDK4/6 inhibitors in advanced breast cancer. So my disclaimer is PPT is provided by DRL people, and I have edited some slides in it. And while I was going through all slides, I felt like defense lawyer, which was not needed by DRL. So the management in metastatic breast cancer, hormone positive, HER2 negative. So story started with tamoxifen, 1977. Then came aromatase inhibitors, non-steroidal, that is anastrozole and letrozole. And after that, exemestane, and then fulvestrant in 2002. So we got around 10-month PFS in first line, but we were not happy about it. And we wanted to do more for patients. So we will see what can we do. So these are some 4-5 slides are mine. So what is CDK? That is cyclin D kinase. And what is its role? So I just want to highlight that CDK generally phosphorylates cyclin D, which plays important role in cell cycle progression from G1 to S. In terms of it phosphorylates RB, and when RB is phosphorylated, E2F is disconnected with from RB, and it will lead to G1S progression. So when we add CDK4/6 inhibitors, we stop this cell cycle progression, and we arrest a cell in it. So that is fine, but what is its relation with HR positivity? HR positive, HER2 negative, why not TNBC? Why not HER2 positive, HR negative? So the point is estrogen estrogen receptor has two pathways. One is nuclear pathway. So estrogen receptor will go into nucleus and will cause some changes. And the other pathway is cytoplasmic, which will basically increase PI3 kinase AKT mTOR activity, and which will lead to some genetic modification. And what genetic modification will be there? There will be cyclin D upregulation, and CDK4/6 upregulation, which will cause cell cycle progression and cell will divide. So now we know what is CDK, we know what is the relation of CDK with HR positivity. Now, how many types of CDK? So there are 16 types of CDK. That is very important to know. But why we are interested only in CDK4 and 6? Because you can see in the second column that only cyclin D is associated only with CDK4 and 6, and we want to highlight that we want to inhibit the cell in G1 as progression. So we are interested in CDK4/6 inhibition. All are CDK4/6 inhibitors. I mean to say all cyclibs are CDK4/6 inhibitors. Palbo, ribociclib, yes, but abemaciclib CDK4 selectivity is there. Abemaciclib generally inhibits CDK4 only, not CDK6. And why it is important? So abema people try to inhibit CDK4 only because CDK6 is present in only bone marrow. So abemaciclib doesn't suppress marrow. Now all slides are from DRL people. And before going into it, I just want to highlight my interpretation of all CDK4/6 inhibitors. So I am interested in common things. So common things in ribo, palbo, and abema is cyclib, or all are cyclib. And all these trials of palbociclib, ribociclib, and abemaciclib generally all have a primary endpoint is PFS, secondary endpoint OS. So whenever any trial is set to go, the trial is most powered for primary endpoint, and that was PFS. So across all trials, PFS benefit was there. So my interpretation is cyclib should be added in first line, and it will give PFS benefit definitely. And OS benefit will be dependent on many factors that we will see. So now palbociclib, first in class CDK4/6 inhibitor, orally active selective inhibition of CDK4 and 6 inhibits cell proliferation and cellular DNA synthesis by preventing cell cycle progression from G1 to S phase that we already saw. So PALOMA 1, that was phase 2 trial of palbociclib in endocrine sensitive, AR positive, HER2 negative metastatic breast cancer, and letrozole plus palbociclib versus letrozole alone, and excellent PFS benefit 20.2 months versus 10.2 months, and HR was 0.488. So now this palbociclib and letrozole was the first. So I felt like what DRL people are trying to say is kya palbociclib comes enough at first, then ribociclib and abemaciclib. PALOMA 2 background, that was phase 3 trial, same letrozole plus palbociclib versus letrozole alone in first line. And study design was eligibility criteria post-menopausal, that is important. Pre-menopausal was not included. And PS 0 to 2, randomization palbociclib plus letrozole versus letrozole alone. And primary endpoint was PFS. And secondary endpoint was OS. So baseline characteristic, one thing I wanted, I'm convinced by these slides are less than 12 months, the disease-free survival less than 12 months, there are 22.3% patients were less than 12 months DFS. So those patients were high risk for progression. PALOMA 2 updated investigator assessed PFS. So PFS excellent phase 3 trial, 27.6 versus 14.5. 0.5 was HR, so excellent PFS again, additional 13.1 month benefit. So time from randomization to first subsequent therapy, so again 10.5 months delay in chemotherapy. Analysis of subgroup. So prior hormonal therapy, in all subgroup PFS was better than letrozole alone. So now comparison of palbociclib, ribociclib, and abemaciclib. We are talking in first line. So they tried to highlight that HR was 0.488 and 0.563 in palbociclib, 0.568 in ribociclib, and 0.54 in monarch. But I wanted to highlight that absolute benefit of palbociclib was 20.2 months versus 10.2 months, and PALOMA 2 27.6 months versus 14.5 months, whereas in ribociclib 25.3 months versus 16 months. Means absolute benefit was actually increased in both arms. And abemaciclib as well, 28.1 month versus 14.7 months. So final PALOMA 2 ASCO 2022 final OS analysis required events were reached with median follow-up of 90 months. And palbociclib plus letrozole median OS only roughly 2 to 3 months increased with hazard ratio 0.956, and that was not significant. P-value was 0.3. So overall OS was not significant. Factors impacting OS. Now they have explained why overall survival was not met. So disproportionate loss to follow-up or missing survival data, that was first excused. Second was disease-free survival. This point I am convinced actually, because these 22% patients were high risk for progression. So this subset can cause this result of non-significant OS benefit. So less than 12 months, only 22% patients were less than 12 months DFS. So combine PALOMA 1 and PALOMA 2 OS analysis, and that in subgroup DFI more than 12 months. Now that is important, and in that hazard ratio is 0.7, and which is significant, and median OS 64 months versus 44 months. So again, they try to explain that a real world situation is different than randomized control trial, that we all know. Now FLATIR-on-US, that is another slide. I am convinced, and I am very interested in phase 4 studies when there is discrepancy in phase 3 studies. So in phase 4, post-marketing, actually the unadjusted analysis and propensity score matching showed that for OS, HR was 0.63, and for propensity score matching, HR is 0.58, and that is significant. P-value is very significant. So post-marketing data analysis showed that palbociclib has also OS benefit. So in subsequent line, PALOMA 3, that is after progression on endocrine therapy, on or within 12 months of adjuvant or on therapy for advanced breast cancer, and they have combined palbociclib plus fulvestrant versus fulvestrant alone. And they also got primary endpoint was PFS, and they got it in this trial. PFS, additional PFS benefit was 6.6 months, and median PFS 11.2 versus 4.6. So significant PFS benefit. So PFS in patient with visceral metastasis, again, it was 5.8 months of additional PFS benefit. That is a good thing. Less than 50 years of old, again, significant PFS benefit. 3.9 months of additional PFS benefit. Now extended follow-up, PALOMA 3 OS data, and that shows 34.8 month versus 28 month. That is for palbociclib plus fulvestrant versus fulvestrant alone. And confidence interval was below 1, so that is significant. HR 0.8 and HR 0.7. So again, overall survival based on prior chemotherapy administration. So if prior chemotherapy is not administered, those patients did good, and 9.6 months of additional OS benefit was seen in PALOMA 3. So my understanding is the patient who didn't require chemotherapy and she is HR positive, HER2 negative, then those subset of patients are generally good risk, because we generally give chemotherapy in HR positive, HER2 negative when there is visceral crisis. So there was no visceral crisis in those subset of patients, and because of that they got better OS. Overall survival based on prior chemotherapy. So chemotherapy was necessary in this subset, and there was no OS benefit. So matching adjusted indirect comparison of OS with palbociclib versus ribociclib versus abemaciclib. So again, their explanations are that prior chemotherapy for MBC, one chemotherapy before hormonal treatment was allowed in PALOMA 3 versus it was not allowed in Monarch 2 and Mona Lisa 3. And number of prior lines of ET for MBC, endocrine therapy, any 2-3 endocrine therapy failure, PALOMA 3 allowed, but Monarch 2 and Mona Lisa 3 only one prior ET allowed. So matched and adjusted analysis always benefit, but I don't think that any cyclib is better than other cyclib. All cyclib are same because all achieve primary endpoint. That is my interpretation of all data. So we should not just chasing one cyclib with other cyclib. Yeah, but how we should select? So I think we should select on the basis of safety and safety profile of each cyclib, and obviously pocket of patients. If some cyclib is cheaper and safe, then that is preferred according to me. So now safety consideration, Dr. Kalpesh Prajapati will talk about. So thank you.
Anybody has any question? कोई है?
मैं वो कार ड्राइव कर रहा हूँ।
बाल ठीक कर रहा है।
बाल ठीक कर रहा हूँ। इस एडस पे फंस गया यार, इतनी सारी लाइट है ना, यहीं पे फंसा हुआ तब से।
So Asif, I would like to ask a question. Keeping apart finances, is there any particular reasons why somebody would select a PAL-based versus a Ribo versus an Abema? Are there any specific nuances in each of these drugs which one should be looking for, or in the patient for that matter?
Sir, I would say that one should choose according to safety profile first, because efficacy wise, I don't think one is superior to another. First thing. Okay. Second thing, cost. Second thing, cost. If cost is cheaper,
keep cost aside. Cost, I don't think there is any difference in the cost between the three. So forget the cost.
Yeah. So your answer will be covered, I think, in second session. Safety profile, because.
No, anything in the efficacy where you favor one over the other in certain subsets of patients, or maybe some particular groups of patients.
Sir, again, if someone has liver issues or someone has bone marrow issues, in those patients, one can choose one drug over the other. So according to side effects and safety profile, I would say.
Chirag sir has any opinion?
So, so far, if you look at the pivotal clinical trials, which is PALOMA 2 for palbociclib and Monarch 3 for abemaciclib, and Mona Lisa 2, 3, 7 all for ribociclib. If you look at the primary endpoint, as Asif was telling, which is PFS, it is same for all the three in whichever subset that you are using, with the hazard ratio between 0.5 and 0.6, somewhere around 0.55. So it looks similar. But if you look at the overall survival, and ultimately there is the important endpoint, whether it is the primary endpoint or not. So far, what we have in all the mature data, that ribociclib is scoring slightly higher as compared to the other CDK4/6 inhibitors. But that is restricted to the few pivotal clinical trials enrolling a few hundred patients. So now we need to look at the larger post-marketing or real-world evidence trial, we should do the meta-analysis of multiple trials, and then that should give us the answer. Is there any merit of one over other? And it looks unlikely, looking at the data which is emerging from the pivotal clinical trial and from the real-world evidence trials, as Asif showed. It looks unlikely that we will have one drug clearly superior over another. So let us see
Okay.
what comes out in coming 2-3 years.
Sir, what about the criticism that the other two have, that some of the patients which were put on these trials were probably not as high risk or bad diseases as was in the case of maybe, let's say, Bima. Ribo, there is always a criticism in favor of Ribo that the patients taken were so good, so it ultimately landed up with an overall survival advantage. Or the patients taken, Abhima guys say that the Palbo guys said that the patients taken were probably more non-selective, or let's say across, so that ultimately PFS was there but did not land up with an overall survival advantage. Any merit into that discussion?
So we had enough of the discussion between Congress and NCP and Shiv Sena and BJP. So it is something similar. So we don't want to enter into that.
Even in the case of adjuvant data, sir, for that matter, adjuvant all of these failed except for Abhima. So again, I won't say it's a criticism, but then they were smart enough to take patients which were extremely high risk and were going to fail. So they got some advantage out of the drug. Is that correct?
Maybe, but unless we have the data from multiple clinical trials and unless we have the meta-analysis, we cannot comment on the subtle differences between the trials.
Abhishek bhai, that was I was trying to say in this slides. They have explained that less than 12 months DFI, and that was 22% in PALOMA study,
Yes.
and that was very high risk. And second was they have allowed chemotherapy, prior chemotherapy before starting CDK4/6. So these 2 points, I am convinced that those 2 points are favoring high risk population, and that can lead to not that great OS data of palbociclib.
Okay,
Kalpesh,
Kalpesh is going to speak on toxicities. Kalpesh.
Kalpesh is going to do the toxicity.
Kalpesh सुई क्यों लाए?
ना.
उधर भी नहीं है.
Kalpesh,
He is
unmute yourself.
muted.
अने बरसात गिर रही है कल्पेश के स्क्रीन में.
हाँ ठीक है बस.
कल्पेश के स्क्रीन में बारिश गिर रही है.
नहीं बस मैं भी वहीं अपने राजपथ में ही. बट नेटवर्क शायद स्लो है क्या है कुछ.
ना कहीं नहीं. Start. Kalpesh, start.
Yes, you are audible, you are visible.
So
we can see everything.
Starting safety consideration, I think I have just what I reviewed today. Probably brain metastasis, abemaciclib is something better we can choose. If, that's the one thing. And for bone only disease, palbociclib has some better data. That is what I found today when I was.
For what?
Bone metastasis only.
Kalpesh, तेरी आवाज थोड़ी बहुत कम आ रही है. Bone metastasis only. Palbase is better. You?
Yes. वैसा कुछ था कहीं. Just I was reviewing all.
હું તને કહું કે એકલું બોન મેટાસ્ટેસિસ માટે ખાલી હોર્મોન ચાલે, પાલ્બેઝની જરૂરત નથી તો કેવું કહેવાય?
Yes. Okay, so with that, let's start with safety consideration for selecting. And as my colleague Dr. Asif has said, there is nothing to choose when efficacy is there. All three drugs have similar efficacy. Probably safety is where we choose decide whichever patient will take what type of CDK4/6 inhibitor. The slides are given by Dr. Reddy's laboratory, and I have not much time to add anything, but at the end of the session I will give 1 or 2 inputs, my own talk. So as said, despite comparable results in clinical efficacy, the 3 CDK4/6 inhibitors, there is substantial pharmacological differences as elaborated by Dr. Asif, and then how this toxicity profile is different for all the 3 drugs, and there are very few, but the differences are consistent, and we can see across all patients. Overall, if we look at palbociclib and ribociclib, both have this bone marrow toxicity, while abemaciclib has produced less neutropenia, but then it is with very high GI symptoms and less pronounced hematologic toxicity. So diarrhea is more with abemaciclib. And so if we see our patient pool, there are some patients who are elderly, some patients who have cardiovascular disease, there are some patients who have deranged liver functions, aminitis, and patients with other comorbidities like diabetes or some other diseases. And these are the 5 most common toxicity we see with these 3 class of drugs. There is neutropenia common with ribociclib and palbociclib, diarrhea with abemaciclib, thromboembolic event is amebaciclib, reversible transaminitis with all 3 drugs, and QTc prolongation is common with ribociclib. And so for elderly patient and with comorbidity, these all things are matters, but with cardiovascular disease patient, probably thromboembolic event and QTc prolongation is more important, while patient who have already liver dysfunction, this reversible transaminitis may increase their burden on liver. If you look at pooled analysis of all PALOMA 1, 2 and 3 trials and combined toxicity, neutropenia was most common toxicity, but majority of them of grade 1 and 2 and grade 3 are 50%, but grade 4 neutropenia was seen in only 10% of patients. Rest other toxicities, as we can see, only grade 1 or grade 2 and nothing much serious except some URTI around 5%. Diarrhea was very minimal, but grade 2 diarrhea was already almost seen in almost 23% of patients. And 1 or 2 important other things are alopecia, that grade 1 or 2 alopecia and grade 1 or 2 vomiting and decreased appetite. There are some troublesome complications that can affect our patients sometimes. So far now the mechanism of neutropenia caused by CDK4/6 inhibitor. While routine cytotoxic chemotherapy drugs, they act on non-dividing cell and do DNA damage. Palbociclib or other CDK4/6 inhibitor causes cell cycle arrest, and that does not result in death of the proliferating neutrophil precursor. And so when we stop this drug, there is rapid recovery of WBC count, and that's why the reason there is no much febrile neutropenia or no mortality is seen. So how we manage neutropenia with CDK4/6 inhibitor? If it is grade 1 or 2, that is ANC more than 1000, we can continue treatment without dose adjustment and can hold if infection occurs. Grade 3 neutropenia, day 1 of cycle, withhold the dose and repeat in 1 week. When if ANC improves and becomes less than grade 2, then we can start at the same dose. If it happens on the first day 15 of first 2 cycle, we can continue current dose to the complete cycle. We can repeat CBC on day 22 and start the next cycle at the same dose if counts recover to grade less than 2. If there is fever or infection and or recurrent infection or recovery is delayed by more than 1 week, we have to withhold the drug till ANC improves to more than 1000, and we have to resume at next lower dose. If it is grade 4 neutropenia, wait until it resumes, ANC improves to more than 1000, and then resume at next lower dose. This is how we need to modify dose in neutropenic patients. So if we modify our dose, and the patient may ask a question that will it affect our outcome, or if we are taking lesser dose, we may have less effect. But the study that was done has shown that no difference in PFS was observed when patients have more than 1 dose reduction because of neutropenia versus no dose reduction, and all patients have almost median PFS of 9.5 months. So if required, we can do dose reduction, and it doesn't affect our PFS outcome at all. Coming to this common toxicity of abemaciclib, diarrhea, Monarch 1, Monarch 2 and Monarch 3. In all trials, any grade diarrhea was seen in almost 90%, 80 to 90% of patients, and grade 3 diarrhea was higher in Monarch 1 and Monarch 2, but in Monarch 3 it was almost less than 10%. As an SAE, diarrhea was reported in almost 1 to 2% of patients in both trials. it resulted in treatment change or treatment discontinuation in almost significant number of patients. Required dose reduction in 15% of patients in Monarch 2 and Monarch 3, and almost 2 to 3% patients require treatment discontinuation due to diarrhea. Almost 70% patients require antidiarrheal medication to control this drug. So how you manage diarrhea of Habemus sleep? These are the standard recommendations. At the first sign of blue stool, start antidiarrheal agents like loperamide and increase intake of oral fluids. If it is grade 1 diarrhea, that is less than 4 stools per day over baseline, no dose modification required. If it is grade 2, that is 4 to 6 stools per day over baseline, suspend dose until toxicity resolve to grade less than 1. If it is persistent or recurrent grade 2 diarrhea happens, then dose must be reduced by 1 step. It's grade 3 or grade 4 diarrhea, that is more than 7 stools per day or life threatening and required dehydration, require admission, then we have to suspend dose to less than 1, and then dose must be reduced on the next cycle. The dose reduction corresponds to reduction of 50 mg of Habemus sleep at a time. So if it is a 150 mg BD, then we have to make it 100 mg BD. And if patient cannot tolerate 50 mg BD, then we have to discontinue Habemus sleep. Another unique toxicity of ribose sleep is the QTC interval prolongation, and this one trial incidence of ribose sleep associated cardiac conduction abnormalities. The conclusion is ribose sleep was associated with significantly higher risk of QTC prolongation and the resultant dosing inconsistency and discontinuation. So patients who are on other medicine that may affect QTC prolongation and increase the chances of this QTC prolongation due to ribose sleep, either we have to switch over to other CDK4/6 inhibitor or we have to monitor them closely. And so to summarize all three trials, PALOMA, MONALISA and MONARCH, QTC prolongation was seen with ribose sleep, and any grade side effect was 3%. Neutropenia is common with PALOMA sleep and ribose sleep, while it was seen less commonly with Habemus sleep, as we know. Diarrhea, although grade 2 diarrhea were seen with all PALOMA sleep and ribose sleep, but GI toxicity, all diarrhea, vomiting, pain and decreased appetite were more with Habemus sleep. Transaminitis grade 2 seen with PALOMA sleep, while it was not reported with ribose sleep trial, and also less frequent with Habemus sleep. Fatigue was common in all three drugs, grade 2 fatigue, but grade 3 fatigue or grade 4 was less than 2%. But this cross trial comparison are unreliable, as they are likely to be confounded due to differences in study design and patient population. So conclusion cannot be made from this, and we need at least phase 4 trial or real world data of the safety. This chart shows the monitoring of all three drugs. We are recommended monitoring. With patients who are on PALOMA sleep, we need to check only complete blood count at every cycle and additional complete blood count at day 15 on cycle, first 2 cycles. If we prescribe ribose sleep to a patient, we need to monitor CBC same as PALOMA sleep, but in addition we need to look for ECG at first cycle, day 15 of first cycle, second cycle, day 1, and then as and when clinically indicated. LFT monitoring is a must requirement in ribose sleep, while in Habemus sleep we need to monitor CBC and LFT at every cycle, and in addition day 15 of first and second cycle. So if we look at this, PALOMA sleep require less stringent monitoring, while ribo and Habemus sleep we have to be very crucial. These are the different dosing recommendation. PALOMA sleep 125 mg once daily, we give 3 week on and 1 week off. The doses reduction are up to 100 milligram, and then second dose reduction is 75 milligram. For ribose sleep it is 200 milligram, 3 tablets once a day, 3 week on 1 week off. If we require dose modification, it's a 2 tablet once a day or 1 tablet once a day. Habemus sleep 150 mg BD, then first dose reduction is 100 mg BD, and next dose reduction is 50 mg BD. FDA label warnings comes with PALOMA sleep. The only warning is neutropenia. With ribose sleep it is QT prolongation, irritability, toxicity. Another unique with Habemus sleep is venous thromboembolism, apart from diarrhea, hepatotoxicity and neutropenia. while this is not mentioned as palbocin slip, but literature mentions that palbocin slip has somewhat increased incidence of pulmonary embolism too. So final slide, what we choose based on safety and patient clinical features. So if patient is with some comorbid like cardiovascular comorbidities, riboside slip should be better avoided because it can cause QTc prolongation, and but palbo and abemaciclib slip can be given. If patient has some GI comorbid like IBS or IBD or something, then abemaciclib slip better avoided, and palbo and ribo can be given. For elderly patient and other patient who have renal impairment, palbo and riboside are better, because diarrhea can cause dehydration, and such patient may load into emergency ward or ICU. If patient has hepatobiliary comorbidity or some liver dysfunction, and if they are with hypoalbuminemia, then palbociclib is better choice over ribo and abema. If there are no hypoalbuminemia, then palbo and abema can be given over ribociclib. If we look at metastasis, for brain metastasis, abemaciclib is a better choice over palbo and ribo. Patient is hepatic metastasis and liver dysfunction. This slide mentions that palbo should be given, but probably in presence of visceral metastasis, abemaciclib has better outcome. If patient is polytherapy, there are more than 5 co-medication are going, and some of them are CYP3A4 inhibitor. We have to look carefully for which drugs are getting metabolized, and probably all three have some interaction with CYP3A4 inhibitors. But here that shows that palbociclib is chosen over 2. That was last slide, and thank you for patient hearing. So I will stop sharing, and Chirag sir can give some comments or questions. ये हमारा बोलवान रही है.
Okay, anybody has any question?
तो समरी में बोल दो ना कौन सा कब यूज करने का बस.
એટલે abemaciclib સાહેબ વિસરલ એટલે એન્ડોક્રાઇન રેઝિસ્ટન્સમાં બી કામ કરે છે, અને મોનોથેરાપી તરીકે બી ઇટ હેઝ સમ રોલ. સો as far as efficacy goes, abema is some better, but and I think with lower doses diarrhea can be managed easily, but still I have not experience of giving abemaciclib, and whatever few patients I have on palbociclib, they are all happy. That is what I can say.
रेड्डी वाला कहीं
Anyone has any questions? रेड्डी वाला palbociclib है. हेलो.
हाँ.
સાહેબ રેડ્ડી ની જ મીટિંગ છે.
એટલે તો પૂછું છું. એટલે તો પૂછ્યું.
Sir, question.
Can you use failure of palbociclib, abemaciclib?
There are no data.
No.
जी तो साहब आई नहीं है.
There is no
in this
data that
ESCO,
one cell cycle can be replaced by the other.
in this ESCO, there was data of using ribociclib after failure of other CDK4/6 inhibitors, and most of them were palbociclib. Some of them were ribociclib themselves, so it was continued, and very few of them were abemaciclib. And there is some early indication that it works with another hormone. So after palbo, ribo can work, but I don't know whether after ribo, palbo works or not. We don't have any data for that. I think the trial name is the alternate trial or something. If someone can, Asif or Kalpesh can throw some more light on that.
The question was abemaciclib single agent is used when?
After multiple hormonal treatment and chemotherapy fails. It is not after the failure of CDK4 inhibitors.
Okay. Are these are these drugs used outside any disease other than breast cancer?
So palbociclib is useful in dedifferentiated liposarcoma.
So that is with CDK4/6 expression or no?
Yes.
Do we have to do any biomarker for that? No.
I don't think so.
No, but આ બધી ચિરાગ એજીએસ પેનલમાં આ માર્કર આવે છે ને થતા હોય છે and people are using them as a driver mutation and
No. This is not driver mutation, and this is not inhibiting any driver mutation.
not exactly driver mutation, but then is it a druggable target?
No, we don't have any biomarkers for using CDK4/6 inhibitors.
I have overheard somewhere કે પેન્ક્રિયાસમાં લોકોએ વાપર્યું છે અને આમાં લોકોએ વાપર્યું છે.
તો બધામાં ઘણા લોકોએ
I don't know what
વાપરી જોઈએ છે.
અચ્છા.
પણ ડેટા નથી એનો સ્ટ્રોંગ.
એ પેલું સાહેબ ફાઉન્ડેશન લખ્યા કરે છે બટ એની કેટલી સિગ્નિફિકન્સ છે નોબડી નોઝ.
હા,
ફાઉન્ડેશન ઘણીવાર પેલું સાયક્લિન ઇનિબિટર્સ કેન બી યુઝ, પેલું CDK4 સાયક્લિન એક્સપ્રેશન છે એવું લખે છે બટ એવું બહુ સિગ્નિફિકન્સ છે ધેટ નોબડી નોઝ. એવું તો ઘણું બધું લખીને છોડ દે છે ફાઉન્ડેશનમાં.
સર ઇન્ટરસ્ટિયલ લંગ ડિસીઝ બી ટોક્સિટીમાં મેન્શન કરેલું છે પાલ્બોમાં. Is it significant or do we see in routine practice?
Pulmonary toxicity.
ના.
PLD.
એ તો પછી અભિમાંથી થ્રોમ્બોએમ્બોલિઝમ થાય 2% લોકોમાં, પણ મને નહીં લાગતું આપણે કોઈ જોયું છે અત્યારે સુધી અહીંયા.
If I can
Is abema more active in liver like brain? This CNS penetration છે એવું કંઈક છે?
ના, એ માર્કેટિંગ પોઈન્ટ છે એનો. ઓકે, બહુ ફેર જ
એ
પડે.
લોકો કહે છે ખરું, એ લોકો CNS પેનિટ્રેશન એનું બતાવ્યું છે, એ લોકો કહે છે એની કોન્સન્ટ્રેશન બ્રેનમાં બાકી કરતા વધારે છે, બટ અગેન નોબડી નોઝ. એ પેલું
like CNS, do they have somebody who has got a significant liver disease? Is it good to use abema?
that is what they claim. કે બેડ ડિઝીઝ હોય લીવર કે બ્રેનમાં થોડું, એટલે નોટ ઇન ક્રાઇસિસ બટ a bad disease, abemaciclib works better than the other hormones, other cell cycle inhibitors. That is what they claim.
But is it better to give chemo if liver dysfunction is likely?
So there is a fine difference between crisis and liver disease. Patient has a significant number of patient disease chair, but he is not in crisis. Crisis you are very clear, not a single cell cycle inhibitor should be used.
એક ટાટા ટ્રાયલ પબ્લિશ થયેલો છે હમણાં 2021 માં. દેખાય છે ને, મેં મૂક્યો છે.
Yes.
હા, તો અને એ થયો છે PLOS 1 જર્નલ છે, એમાં થયેલો છે. અને એના કન્ક્લુઝનમાં લખે છે કે palbociclib and ribociclib when used in routine clinical practice in first or subsequent lines of treatment resulted in efficacy and toxicity outcomes in concordance with those expected from pivotal trials. એવું લખે છે, એટલે બેમાં બહુ ફેર નથી એવું કહેવા માંગે છે.
એટલે પેલું તલાટી સર જે પ્રશ્ન પૂછે છે ને સાહેબ, એનો કોઈ લોજિક નથી. મને એક જ લોજિક લાગે છે જે કે આ લોકો ક્લેમ પણ કરે છે કે અભિમા હેઝ અ કન્ટિન્યુઅસ ડોઝિંગ. there is a continuous dosing અને continuous dosing ના લીધે કદાચ it has a better tumor control or a better આ ખરાબ કેસમાં એનો કંટ્રોલ થોડુંક સ્લાઇટલી બેટર આવે છે because others there is 3 weeks on 1 week off બાકી બધામાં that is what they claim.
But it is their claim. I mean, it has not been substantiated.
It is not.
So
It has been not been proven. But fair
Yes.
enough. Cell cycle arrest. If you go by common sense, these drugs cause cell cycle arrest, and they only claim neutropenia analysis થાય છે. And once you stop the drug, you don't need a GCSF. Cell cycle arrest release થઈ જાય છે, and counts recover થઈ જાય છે. By that logic, you should have a continuous pressure on the cell. એટલે cell cycle arrest should be continuous. If you go by that common sense, there is no science to it. Common sense. Continuous cell cycle suppression રહેવું જ જોઈએ કોઈ પણ કેસમાં, જે કે આ દવાનો આખો ફંડો છે કામ કરવાનો.
We don't know whether that really happens in
આ તો
vivo or
કહું
not.
છું, આ તો હું મારા
Yes,
લેવલ પર કોમન સેન્સ વાપરતો હતો કે ભાઈ આ એકચ્યુઅલી કેમ થાય છે આવું. કેમ કે એ
એ જ
લોકો
સમજાતું નથી.
જ કહે છે કે ભાઈ સેલ સાયકલ એરેસ્ટ થાય છે અને તમે દવા બંધ કરો તો એરેસ્ટ રિલીઝ થઈ જાય છે, એટલે ન્યુટ્રોપિનિયા કરેક્ટ થઈ જાય છે.
એ જ સમજાતું નથી કે આવું શાને થાય છે. ફૂલડા ડૂબી જતા અને પથરા તરી જાય છે. That is the poetry we were learning when we were in school. Anyway, good. ડિનર છે હવે?
ડિનર તમારા પાછળ પેલો સાણંદમાં પરોસી દીધું છે. બધા જતા રહ્યા, બધા જ ભાગી
કોકટેલ
ગયા.
છે. કોકટેલ છે.
ખાલી ટેલ બચી છે, બાકી બધા તો જતા રહ્યા.
સારું સારું, વાંધો નહીં.
ક્યાં ગયા બધા? પેલું ઓન કરીને એક બે જણ તો ઓન કરીને ફરવા જતા રહ્યા લાગે.
ભાઈ मैं हूँ સાંભળું છું. હા,
આપ સાથ में खाना खा रहे हो?
हाँ
નહીં, ઘરે ઘરે.
Sir, another point
Chalo, fine.
I wanted to, sir.
Yes, Asif.
Another point I want to make is breast cancer is always heterogeneous disease. If clinically the case is rapidly progressing, then probably CDK4/6 role is not that much in that tumor subset. Probably tumor suppressor genes are also gone. So in those type of patients in primary endocrine resistance, though it is HR positive, how much CDK4/6 is useful is doubtful for me.
એક પેલું હવે આ તમે પેલું એ વાત કરીએ તો ચિરાગ સર, ઘણીવાર મને એવું થાય, ફાઇનલી વેન ધ પેશન્ટ પ્રોગ્રેસિસ યુ હેવ એવરોલિમસ 2. જો આપણે ક્લાસિકલ પેલી હોર્મોન રિસેપ્ટર MBC ગણીએ તો અલ્ટિમેટલી યુ આર વિથ એવરોલિમસ એક્ઝિમેસ્ટેન. ઘણીવાર એવરોલિમસ બેઝિકલી વી ઓલ નો પેલું બાયપાસ મેકેનિઝમ પર mTOR પર કામ કરે. ઘણીવાર મને એવી ટેમ્પટેશન થાય આપણે એવરોલિમસ વિથ પાલ્બોસિક્લિબ વાપરીએ તો કેવું રહે? કોઈ ડેટા છે?
એક ટ્રાયલ હતો, એ હું ભૂલી ગયો છું અત્યારે, પણ પાલ્બોસાઇક્લિન હતો, રાઇબોસાઇક્લિન હતો, કારણ કે રાઇબોસાઇક્લિન B001 એ હા એવો ડેટા હતો, પણ that was not successful data.
અચ્છા, ઓકે. કેમ કે આ તો અલ્ટિમેટલી રેઝિસ્ટન્સ જ ઓવરકમ કરવાની છે ને.
Yes.
ચલો ધવલભાઈ,
Hello.
you are there? Is there anything else? ધવલ પોતે જ જતો રહ્યો, રેકોર્ડિંગ લગાઈને પોતે જ ભાગી ગયો.
નહીં સર, છું.
છે કઈ બીજું?
Sir, I am not qualified to make any comment, sir, against
So
you.
I'll make a comment. બધા ભાગી ગયા, but palbociclib પેલી why he has done this is because Dr. Reddy's has come with palbociclib.
Yes,
અને
sir.
પેલો આસિફ નો પેલું whatever Asif said is right. There is nothing પેલું આ તો પેલું બાલની ખાલ કાઢીએ છે બધા ત્રણમાંથી. There is nothing major to choose between all of the three. What I think is different now is probably I think Dr. Reddy's કઈ 9 months પછી ફ્રી આપે છે ને 10 મહિનાની જગ્યા, એટલે
Yes, yes.
બીજા કરતા કદાચ પેશન્ટ ને 80,000 બચે છે. એટલે પેલો કઈક 8 લાખ આપવા પડતા હતા, બધામાં 8 લાખ થાય છે, આમાં થોડાક ઓછા થાય છે, 1 મહિનો ઓછો ભરવું પડે છે. That is the difference right now. between
બીજું સર we have a direct billing તો સર પેશન્ટને જે 5-6% નો બીજો પર એડવાન્ટેજ થઈ શકે સર which other not possible with other brands. Just
right
5% is not much, but still.
એટલે એક એ છે
3,000 for 12 months, sir. 40,000 is the cost of actual benefit.
એટલે a little maybe 1 લાખ રૂપિયા બચે છે પેશન્ટ ના.
Yes, yes.
જો borderline patient હોય તો એ ફરક પડે.
Yes, sir.
Efficacy wise, there is, as you all said, there is nothing great
Yes,
about all the 3 drugs. They are practically the same. So we can choose any of the 3. Palbase is possibly, we have used it since the last 5 years, so we are probably more used to it. That is the thing about it. Baki bada are still a little enigma.
Yes,
We
yes.
have some trouble or we have some hesitations using it. So that is what he wanted to put through. હું બોલ્યો તારી બદલે બસ.
Thank you, sir. Thank you.
મેં આજે MR ની નોકરી કરી લીધી.
આ ફાઇઝરે ચલાવવા આપી છે કે તમે પોતાની જનરિક છે આ?
No, sir. It is a licensed original product from Pfizer, sir. It is not a generic.
So Pfizer is simultaneously going to market it or not?
At present, sir, they are scaling back actually. Only 20% field force is there, sir.
ફાઈઝર ઉદ્ધવ ઠાકરે છે અને આ લોકો શિંદે છે.
Yes, sir. હવે શપથ લઈ લીધી છે, sir. Rightly said. And also patient assistance is also all set up, sir. RxCS પણ છે, where if patient needs some financial help, so based on their assessment, that also can be extended, sir. So that is it, sir. એક patient છે, sir. અત્યારે we have enrolled already from HOC. So it is there, sir. But thank you, sir. Thank you very much for giving this opportunity, sir.
ચાલો, ગુડ નાઇટ.
Good night. Thank you.
Thank you. Thank you very much.